As we were talking before this section with Konstantin, it really is a very important topic, and it lies on my heart. So, I'm Linda Kühn, and as you see, I'm not only an anesthesiologist and intensive care specialist, but yes, also a psychotherapist. At first, this may look a little bit weird, like a kind of weird subspecies, but it's becoming more common in our field. So that's exactly why I'm here to talk about post-intensive care syndrome, or short PICS, and what can we do together on the ICU. The Society of Clinical Care Medicine first defined PICS in 2010 as a new or worsening impairment in physical, cognitive, or mental health status that arises after critical illness and persists way beyond acute hospitalization. Later works also emphasize that post-intensive care syndrome family, which refers to the psychological and existential burden carried by family members of ICU patients, is also present. This definition has become the foundation for research, clinical guidelines, and interventions we'll discuss today. While luckily, ICU mortality has decreased, we now see a growing burden of morbidity. Many patients lose independence, as Harridge and colleagues showed that up to 40% remain unemployed 1 year after discharge. Beyond the individual, this has profound consequences for families and the society. To illustrate, here's a patient from my psychotherapy practice. He was a 45-year-old male, and he was a former professional athlete. So you can think about as a very physically resilient person who got a very severe COVID-19 and got to the ICU approximately 2 weeks, and also 4 days of ventilation. Yeah, while many of us are interested in the details of the ICU stay, I know, but from this part, I don't know that much because I knew him as a psychotherapy patient. And despite being very resilient, also physically and also mentally, after discharge, he developed panic attacks and post-traumatic distress syndrome. He required antidepressants and anxiolytics, but also after 6 months of treatment, he did not really get well. So alongside with that, psychotherapy was also very important for him. Now he's working and he's back to his family and with his kids and very happy in his life, still having some issues, but he can handle them very well. So that can be a very good case to follow. This case underlines that even younger patients who are physically fit with relatively short ventilation time can develop severe psychological sequelae, highlighting the unpredictable impact of critical illness and the need for structured follow-up. Post-intensive care syndrome spans over three domains: physical, cognitive, and psychological. These frequently overlap, and they don't stop at the patient. Families often carry anxiety, depression, or even PTSD as well. Seeing it as a multi-domain syndrome helps us structure both assessments and intervention. The prevalence varies by domain. Roughly 1/3 to half of patients develop physical or cognitive deficits, while psychological sequelae affect a little bit less, around 30–40%. Heiser and Needham had a study that showed that risk differs by admission type. Patients after urgent surgery had the highest rates across all domains. Medical admissions somewhat lower, and the elective surgery, as one could guess, the lowest. They use validated tools such as the Montreal Cognitive Assessment for cognition and activity scores for physical outcomes, and standardized PTSD and depression questionnaires for psychological symptoms. This shows that risks are not uniform but present at any type of admission. Psychical sequelae of post-intensive care syndrome include ICU-acquired weakness, pulmonary impairment, and long-term exercise intolerance, which is then in connection with the mood, motivation, and all the rest of a person's life. Physiotherapy and pulmonary rehabilitation are crucial to address these ones, but nutrition also plays a role. Recent studies underline how critical illness disrupts the gut microbiome. I guess there was also a presentation about this. And this may fuel systemic inflammation and also has been linked to depression. So everything is connected to everything and illustrates the overlap between the physical and psychological outcomes. Cognitive impairments are among the most feared outcomes of post-intensive care syndromes. Patients often experience memory deficits and difficulties in executive function, which sounds very sterile when we are talking about this, but when you have a family member who does not know how to get to the bathroom because loses his way from the living room to the bathroom, it's getting more under your skin. So meta-analysis estimates 30 to 50% prevalence months after ICU of these impairments. Pentaparidane's landmark study showed a clear dose response. Each day of delirium increases the risk of long-term impairment. Psychological symptoms include anxiety, depression, PTSD, often persisting well beyond discharge, as seen by this patient I was talking about. Patients frequently recall frightening ICU memories, like sensations of falling or floating, worsened when explanations were missing. I will talk about that a little bit later. Families can also be strongly affected with PTSD even. Simple interventions such as ICU diaries, positive continuous communication during the care can mitigate these outcomes. This is very important. So what we do and how we do can really make an impact. Risk factors can be grouped as non-modifiable, sadly, potentially modifiable, and modifiable. Of course, age, sex, or comorbidities we cannot change. Potentially modifiable factors, yeah, there can be a little bit, can be influenced by early recognition or supportive care, but most importantly, there are factors we directly control every day in the ICU. The depth of the sedation, the cumulative sedative dose, immobility, and delirium, these present opportunities to reduce the post-intensive care syndrome risk through targeted practice. So having looked at the risk factors, let's turn to what we can do in the daily ICU practice. I know we all love to have one magical solution, but here we are again. This is a bundle. The most established framework is the ABCDEF bundle, or also called the A2F bundle, where A stands for assessing, preventing, and managing pain. Just to highlight, because untreated pain increases delirium risk and complicates mobilization, of course, with other problems too. So B is about both spontaneous awakening and spontaneous breathing trials, wake-up calls, which reduce sedation exposure and shorten ventilation duration. C highlights the careful choice of sedatives and analgesics, favoring agents with less delirium risk, and aiming for lighter sedation. Yeah, this is, I guess, an ongoing debate with nurses, but we know how important it is. D is for delirium. Regular monitoring is already something that makes a difference. With validated tools and prompt management with non-pharmacological strategies first. E is early mobility, which prevents ICU-acquired weakness and supports cognitive recovery even. But also the motivation is a very important part of this. And finally, F stands for family engagement, which reduces anxiety, helps the orientation very importantly, and supports a recovery after the ICU. Evidence shows that higher compliance to this bundle is associated with lower delirium, fewer days on the ventilator, and improved survival. Each element of this bundle would actually deserve its dedicated talk And I know many of you have already spoken, listened to excellent sessions about sedation choices, deliriums. You know a lot about that. What I'd like to do here is to take two of the elements, early mobilization and ICU diaries, as examples to show they can directly influence long-term recovery. Early mobilization means beginning physical activity within the first ICU days, tailored to what the patient can tolerate. Sweeker's trial, published in Lancet in 2009, showed that early physiotherapy increased independence at discharge and also reduced delirium duration. This is an example of how the elements of the bundle are interdependent. Later studies and also some guidelines reinforce this. Mobilization can be made safe and feasible and reduces ICU-acquired weakness. Adjuncts might be to use, such as cycle ergometry, resistance training, or even neuromuscular stimulation. They can help when active movement is limited. And so we can see that the bundle, how interdependent the elements of it, the bundle are, and how an ICU intervention translates into better long-term outcomes. The second example I'd like to highlight is the ICU diaries. I guess many of you are well aware of this intervention and maybe use it on the intensive care units. I bring it up here because it's simple, low cost, and yet has robust evidence for reducing long-term psychological distress. ICU diaries are just logs, structured logs, kept by staff and family during the patient's ICU stay, often with daily entries and even photos. They can help patients later reconstruct the ICU experience, filling memory gaps and making sense of what happened. A randomized control trial by Jones and colleagues showed that diaries significantly reduced PTSD symptoms in survivors. And the German guideline also gives the diaries a grade A recommendation, so it's very in, I would say. And this is a striking example of how relatively simple intervention, writing a diary during a daily care, can have a meaningful impact on long-term psychological outcomes. And don't forget, psychological means also physical, because they are so correlated because of the motivation and mood. So alongside mobilization and diaries, another intervention that patients themselves emphasize is communication. Qualitative studies show that some of the most frightening ICU memories are not just about pain or procedures, but also about sensations of falling and floating or being moved, especially when no one explained what was happening. What makes a difference is clear, continuous communication, even with sedated and delirious patients. And the way we phrase things also matter. Positive language, such as, "We hold you strongly," "I take good care of you," or "I do everything to make it as convenient for you as possible," are perceived much better and safer than, "Don't be afraid, you will not fall." I guess it's evident, but I guess we all hear it in the everyday work, how positive talk can be, a little bit better, or could be a little bit better used. This is a powerful reminder that not all effective interventions are costly or time-consuming. Talking to patients during care has a strongly influence of how they remember the ICU stay and what their subconscious has recorded. So far we've looked at interventions we can implement during the ICU stay, but recovery doesn't end at ICU discharge. The critical care work we do is the foundation, and what comes next is about ensuring continuity, raising awareness that many patients will still need structured support, and therapy in the months that follow. Systematic assessment and screening give us a way to identify who needs that support. Screening is recommended at the first 3 months and from 6 to 12 months after discharge to identify high-risk patients and connect them to appropriate follow-up care. Assessment and screening are only meaningful if patients have somewhere to turn afterwards. In many regions, dedicated post-ICU follow-up clinics are still rare, but they represent an emerging and promising model of care. These clinics bring together multidisciplinary teams, intensivists, rehabilitation specialists, psychologists, nurses, and social workers to address the multiple dimensions of post-intensive care syndrome. Where such clinic exists, early involvement is associated with better recognition and management of problems like PTSD, depression, and persistent weakness. Importantly, they also offer continuity, sometimes even involving the same ICU staff who cared for the patient, which survivors describe as reassuring and validating. Telehealth may also provide new opportunities to expand access in the future, and the broader idea is structured continuity care, bridging the ICU stay and long-term recovery. Even if you don't yet have these clinics widely available, being aware of the model helps us advocate for and move toward it. Yes, continuity of care is vital for patients, but recovery doesn't happen in isolation. Families are deeply affected too. Studies show that 30 to 60% of caregivers experience anxiety, depression, and PTSD after their loved one's ICU stay. The risk is, of course, higher when the patient experienced delirium, died, or when communication during ICU was difficult. Again, something we can influence. This is what we call the PICS-F. Addressing it is not just an optional extra, it's a vital component of holistic critical care. So structured recovery programs aim to bring all these dimensions together. To understand what really makes a difference, it's worth looking at the patients, what they themselves report as most helpful in their recovery. When patients were asked what helped them most in recovery, several themes stood out. First, continuity of care. Seeing familiar ICU staff in the follow-up was highly valued. Symptom management, both physical and psychological, gave them reassurance that their problems were real and being addressed. Education and realistic expectation setting helped them understand what recovery might look like, and validation of progress, even small steps, was described as motivating. Emotional support, often from both professionals and peers, was essential, according to McPeak and colleagues' trial. So we looked at what patients tell us and what helps them most in recovery. To close, let me leave you with a few take-home messages. Survival is not the same as recovery. Post-intensive care syndrome affects multiple domains, physical, cognitive, and psychological, and families as well. Risk factors are not all beyond our control. Many are modifiable in daily practice, such as the use of sedation, mobilization, or communication. And importantly, not even intervention is costly. Not all interventions are costly or time-consuming. Some of the most impactful ones are simple, like talking to your patients, involving families, or keeping a diary. Finally, recovery doesn't end at ICU discharge. It requires continuity, structured follow-up, rehabilitation, and recognition of ongoing needs. This is where we as intensivists and colleagues across disciplines can make a real difference. Thank you for your attention.